Hello and welcome to this edition of Your Health, Your Wealth. And I'm excited about my guest today. We're going to talk about utilization management and prior authorization and those things that really can interfere with the delivery of health care. So just a couple of rhetorical, have you ever wondered why after you leave your doctor's office, it takes so long to get things done? Once a physician says they want to do something or institute some type of treatment, there's like this delay between when you actually get that done. Or if you ever heard back from your doctor and they said, well, you said you want to order this, but you said they're waiting on insurance approval or prior authorization. So today I have a guest who's a leading expert on this, and he's going to help us to understand some of these things that can lead to these delays in care. So my guest today is Dr. David Charles. Dr. Charles is a professor and vice chair of neurology at Vanderbilt University. He served as a health policy fellow in the United States Senate and currently serves as the chief medical officer of the Alliance for Patient Access, which is a nonprofit that prioritizes patient-centered care. So I'm excited to hear more about that, and he's going to tell us all about that organization as well. So welcome, Dr. Charles. Can I call you David? Is that okay?
Yes, of course.
All right, David, welcome, and thanks again for joining me. Now, we first met a couple of months ago at the Texas Neurological Society conference, and you gave a really good talk about some of the things that we're going to talk about today. And it's an important issue because, patients need to understand what is meant by utilization management. We are hearing it now. There are legislative things that are happening. So it's important for people to understand what exactly utilization management is, these guardrails that have been put in place that are supposed to reduce the cost of healthcare. Healthcare costs in this nation are now at about $4.9 trillion, almost 18% of the GDP. But programs like utilization management were created to help physicians put some guardrails, not lead to excessive costs or ordering extra tests. But these programs in some situations have led to the opposite of delays in care. So let's start off by tackling the big question, the one that a lot of people want to know about is, prior authorization. So if you can, just enlighten us a little bit more about what exactly is prior authorization, and tell us more about how these can sometimes lead to delays in care.
Certainly. So first, let me say thank you, Dr. Patton. Thank you for the opportunity to join today on Your Health, Your Wealth. And I'll be speaking today representing the Alliance for Patient Access, where I serve as Chief Medical Officer. And you should also know, my practice, I'm a neurologist. I'm in practice in Nashville, Tennessee. I take care of people with Parkinson's disease and related conditions. And so prior authorization is when the clinician and the patient are in the room together and they make a decision about a diagnostic test, maybe it's a medication, and then the visit ends and the patient leaves, but they don't get what they just decided. There's a step in there that always slows down the process. Let's say the patient, I've decided that an MRI is needed. Well, they can't just go get the MRI. There's going to be someone at their insurance company who's going to want to look at that. It's going to delay things, going to delay getting the MRI, or we've decided on a medicine. And they go to their pharmacy, but it's not approved. They have to get prior authorization before they can get that prescription filled. And here's what I've noticed. When patients are subjected to this, two things happen. One, they become frustrated because they just were with their doctor and decided what was needed. And then they become anxious, right? Remember, what we're talking about is someone's health, and when I go to the doctor and when people come to see me as their physician, often they're concerned about their own personal health. And so you have that concern. We all have felt that, all experienced that by the time you're an adult. And then you have some creepy third person that you never really get to see, who gets in the middle of what you and your doctor are trying to do. And that delay in getting access to care is very frustrating to patients, and it makes them even more anxious about their health care. So it's prior authorization is when the insurance company says, no, wait, we want to take a look at things before we're going to agree to cover whatever it is, whatever medicine or diagnostic test it is.
And you talk about the frustration to patients and, to physicians too, because of course the patients don't know what's going on. So they're calling, my office, they're calling our office and saying, hey, what's going on? And that frustration of phone calls can sometimes affect the physician as well and lead to burnout and other things.
Absolutely. So in the prior authorization process, some paperwork happens, and sometimes the insurance company approves it and sometimes it doesn't. And we've all seen, what's transpired in the news over the past several months about health insurance companies denying access to care to patients. And you're exactly right, Dr. Patton. It also leads to burnout for physicians because here's what happens. Let's say that there's a prior authorization and the insurance company says no. And the patient calls my office, they call your office, and now they're like, now what do we do? And you say, well, we have to appeal this. Okay, what does the patient experience? More delay, more anxiety, more frustration. What does the physician experience? Same thing. Frustration. So now we have to do what's referred to as a peer-to-peer. We're going to talk to a medical professional that works for the insurance company, have a conversation about why I think this patient needs this medication or why they need this particular diagnostic test. And so what does that do? That takes up my time, right? The longer the insurance company can tangle me up in conversations and in paperwork, is more time that I can't spend with my patients. And it's incredibly frustrating. And I've had the case where I do the peer-to-peer, and then the doctor for the insurance company says, no, we're not going to pay for it. So then we appeal again.
Yeah.
And fortunately in our state, we can appeal outside the insurance company, and they're bound by what happens in that external appeal, as it's called. Mm-hmm. And so I've had to do up to 3 appeals before the insurance company would agree to cover whatever the issue was, the medicine or the test.
Wow. And mind you, during this time, because this has actually happened to me, and it's an example that I use when I'm speaking on this, is, a patient's condition could be worsening. I had a patient who had a serious relapse, and I've had one patient that actually passed away during this appeal process when we were trying to get these medications. So these delays can be costly from that standpoint as well.
Yeah, let me expand on that. So I will share that I have hypertension, have high blood pressure, and I take medication for that. And my blood pressure is not, scary high, but I need medication. And so if my insurance company said, we want to prior authorize, your medication, and let's say it delayed 3 days. Okay, that's okay. I mean, even talking about myself, right? That's okay. Mm-hmm. But here's what health plans are doing now. They're putting prior authorization on more and more things. And what they've learned that is if they put a prior authorization on something, some sort of test or a medication, about 60% of the people who are prescribed that test or that medicine just won't get it.
Wow.
Right? And why won't they get it? Well, a lot of people can't fight the battle, right? Yeah. So if I have a patient whose daughter is a lawyer and we get tangled up with the insurance company saying they're not going to cover something and I do an appeal and all of that, and if the patient's got, a family member, a child or someone who can advocate for them, right, who's going to latch onto this and they're not going to stop, right? They're going to fight it. Okay, they're going to get approved. Every time we've had to take it to an outside appeal, an external appeal, always approved.
Yeah.
But what about the patient that doesn't have that? What if I'm caring for an elderly person whose spouse has died and the problem we're facing is early dementia? Their cognitive abilities are slipping, right? Mm-hmm. They don't have the wherewithal to fight. They don't have the wherewithal. So they fall into that bucket of people who just aren't going to get whatever it is.
Yeah.
Right? It's very unfortunate. In fact, these activities disproportionately affect at-risk populations.
Yeah.
right? If you're wealthy and you got a child who's an attorney, you're going to get the insurance company to approve it because they're not going to let it go. If you're poor, if you can't miss work to take up these phone calls and these battles, then you're just not going to get it.
Yeah. That's, it's incredible. And that leads to this whole, issue about social determinants of health. And I have seen that as well, where unfortunately you do see that disproportionality in certain communities. So one other thing on this before we move on, but are you familiar with the gold card and legislation that came out of the state of Texas to help with this? And I know it's been kind of bogged down with a lot of regulatory changes, but are you familiar with this? And do you think that may be an avenue that we can hopefully reduce the burden with these prior authorizations?
Well, here's what I understand about it. The idea would be that, look, if you have a physician who is very current on the latest practice guidelines and understands that there's not unlimited resources in healthcare, we've got to be mindful about how we spend. And if you have physicians that have a track record of following practice guidelines and being very mindful of that, then why can't those physicians have a gold card? We'll call it a gold card. And what that would mean is that they could prescribe a test or prescribe a medication and it wouldn't be subjected to prior authorization, while another physician who doesn't have that status would be subjected to the prior authorization process. So from my point of view, this is a step in the right direction. This is a step that says, look, this prior authorization is too much of a burden. If it becomes every medicine and every test for every patient every time, right, it's going to just suck healthcare resources out of the system doing these regulatory arguments instead of taking care of the patient. So from my point of view, I think programs like this, the intention is excellent.
Good.
Part of the challenge, though, is when the rubber meets the road, how are these put into place? What are the criteria to qualify? What's included? What's not included? So all the devil's in the details, if you will. And so we'll see how these play out. And I'm interested to know how it's playing out in Texas.
Yeah, well, time will tell. We're constantly fighting that battle, and hopefully we can get this implemented and get some of these gold cards actually out to see if it helps people. I want to shift gears a little bit and talk about another program that I really struggle with. And in neurology, we see this a lot, and it's this whole concept of step therapy. And what step therapy is basically a program where an insurance company will say that you will have to fail certain treatments that may be on their formularies and so forth before they will allow you to give the patient what you initially thought would be best for them. And this has to do with tiering and the insurance companies and those types of things. But, tell a little bit more about your experience with step therapy and explain to why it's important for patients to know about this, especially as they go into open enrollment and thinking about their insurance for the next year.
First of all, we're referring to it as step therapy, but you called it what it really is, fail first, right? Insurance companies hate that, right? That because the patient understands what that means when you call it fail first. Step therapy is kind of a euphemism, right?
Yeah.
But here's the thing about step therapy. Step therapy, in some cases, is actually good medicine, right? We're taught in medical school. So I've disclosed I have hypertension. Okay, someone who has borderline hypertension, what's the first step to address that? Working with your physician, the first step is diet and exercise, right? Okay, and then if that doesn't work, what is the next step? The next step may be a low-cost diuretic, a very simple medication, very inexpensive. Try that. If that doesn't work, then what's the next step? Maybe it's going to be a more complex medication, maybe more expensive. So that's step therapy. Step therapy in and of itself is not a bad thing. Here's what is a bad thing. What is a bad thing is when insurance companies apply step therapy in a way that's one of two issues. One, they create steps that are so onerous that patients can never navigate it. Let me give you an example. We found a plan in the state of Illinois that had 13 steps before a patient could get access to a hepatitis drug. 13 steps. Guess what one of those steps were? One of the steps was you had to see an in-network specialist in liver disease, a hepatologist. Guess how many hepatologists the insurance plan had in-network for the entire state of Illinois? One.
Yeah, I was going to say one or two.
Everybody in the health plan, if they wanted this medicine, had to go see this doctor, right? And they had to travel at their own expense. One doctor in the entire state. So the steps are so onerous that patients never make it through. Okay, so that's one way that step therapy is abused by health plans, right? Mm-hmm. What I described in hypertension is good medicine. 13 steps, like what I just described for a hepatitis drug, that's abusing patients, right? Yeah. Okay, here's the second problem with step therapy. It's being applied more and more, this fail first strategy. It used to be that step therapy would be applied to something like hypertension, right? It's not an emergency. We've got time to work on it. We're going to get this blood pressure under control, and we're going to take some reasonable steps to do that. Now what health plans are doing is they're applying step therapy to conditions when you fail, you don't get back what you lost. Multiple sclerosis. Maybe that's what you were referring to. Now there are amazing medications for multiple sclerosis, but the insurance plan might say to the doctor and the patient, well, I know you want this medicine, but no. This other one over here is much cheaper. And the doctor's like, yeah, but that's not the one the patient needs. Well, they've got to take it and fail it before you can really get the medicine you want. Okay, what does that mean for the patient with MS? It means they have a flare, an injury to the brain or the spinal cord that they will not recover. Whatever they lose in that flare, they've lost it for the rest of their life, whatever part of their brain or spinal cord it affects. Worse than that, they're now applying it to cancer treatments.
Yeah.
So let me give you, if step therapy is a euphemism for fail first, you know what they call it for cancer patients?
What's that?
They call it a care pathway. Doesn't that sound nice? A care pathway. Come along, patient, and walk with me on this pathway. Imagine a path through, a beautiful forest. No, let me tell you what a care pathway is. It's also fail first. In a care pathway for cancer, you have to take this drug first. And if your cancer spreads, well, then we'll let you take this next drug. Oh, but then if it spreads even further, you can take this drug. Right, all the while, the cancer's spreading and potentially going to take the person's life. When the insurance plan denies access to the first medication or therapy that the doctor thinks the patient needs. That's a situation where it's just so infuriating.
And I'm glad you mentioned that, because the whole notion of fail first, and I like that, I'm still using that, is that it's so different from different conditions. Like I treat like migraines. For if you have an extra 1 or 2 headaches, okay, maybe that's not as bad. But in multiple sclerosis or in myasthenia gravis, some of the things you're treating there, a failure, like you said, could be a relapse. So in myasthenia gravis, weakness where you can't work or take care of your family. So, that whole notion is just in my view, taking the strength out of physicians' hands and putting it more so into the insurance hands.
Yep.
Another troubling thing that I have been exposed to recently, I had a seizure patient who had been stable for years and all of a sudden started having seizures again. And I was trying to figure out, we didn't change the medication dosage. I asked about lifestyle changes, all those things, and everything was pretty stable. And come to find out that the pharmacy had switched her generics without telling me or, the patient. Have you seen this, and where does that fall into this whole realm of what we've been talking about? Okay,
so to be clear on this one, we're talking about generic drugs, okay, and generics are okay. Generics aren't a bad thing. So, for instance, let's say that you've got a child with an ear infection, and the pediatrician's going to prescribe amoxicillin, common antibiotic, right? There are several generic makers out there that are high quality, and you go to the pharmacy, you get the amoxicillin for the child, and they mix it up right there, and the child starts taking the medicine, everything's good. Here's the problem in epilepsy. In epilepsy, one generic compared to another one may not give the same blood level of the medication. So why is that? Well, the FDA allows a window of therapeutic efficacy. So let's say you've got the brand name drug and one tablet 3 times a day gives you a level of, let's say, 10. Okay, and when the generic comes on the market, they have to show that they're generically equivalent. But the FDA allows a window. So if 3 tablets a day gets you a 10 for the brand name drug, as long as the generic is within a certain percentage of that blood level, then it's approved as a generic. But here's the difference in epilepsy. In epilepsy, when you go from one generic to another, that window that the FDA allows may be enough for the patient to have seizure breakthrough. In other words, on one generic, 1 tablet 3 times a day gets you a level of 10 and good control of seizure. Then next month when the patient gets their medication filled, the pharmacy has a different generic manufacturer. And 1 tablet 3 times a day on that medicine leaves the patient with a level of 8.5. Close, but not 10, and they experience breakthrough seizure. So here's what's been done in many states, and my state, Tennessee, passed this. States or pharmacies in the state of Tennessee, if they change a patient's medication for epilepsy, if they have, generic company number 1 for 3 months, and then, 3 months later they got a different generic company coming in there, they have to notify the patient and the doctor that the generic manufacturer changed so that the doctor can draw a blood level if needed to check where is the patient's level on this new generic medication. For amoxicillin, for the child's ear infection, that little window that the FDA allows, no problem. Mm-hmm. For anti-seizure medications, anti-epileptic drugs, it can be a big, big problem.
Yeah, as in the case that I saw, and when I heard your talk about these things, I think it's important for people to know that you may want to ask those type of questions, particularly if you have a condition that's really particular, like seizures or blood pressure, anything where those different changes in the medication can make a big difference. Now, we've talked a lot about the impact that this has on patients and what they have, but as you alluded to in your introduction, there's a huge burden that physicians have to do in this administrative paperwork and everything else. And a lot of times patients don't know that this is what's going on behind the scenes. So in your experience and your work with the Alliance, how have you seen these non-clinical tasks affect physicians and patient care and burnout and things like that?
With the Alliance for Patient Access, we've actually done a study and have a publication on this topic. So these things that we're talking about, fail first, prior authorization, step therapy, generic switching. We haven't talked yet about non-medical switching, but we can touch on that one. All of these activities end up tangling up the physician trying to get the patient access to approved care. And that is not why people go into medicine, to do administrative paperwork and argue about what's the right medicine for their patient. They went into medicine to help their patients.
Absolutely.
But yet they find themselves tangled up in these administrative burdens and arguments. And so it turns out that neurology, our specialty, Dr. Patton, has one of the highest levels of physician burnout among all medical specialties. And get this, there's a critical shortage of neurologists nationwide. Yep. As our population ages in the United States, there's going to be, or there already is, an increasing number of people with neurodegenerative conditions like Parkinson's disease, like Alzheimer's disease, and other things that tend to come along as we age. And so here we have a healthcare system that's driving burnout and the population of physicians that our nation critically needs more of.
That physician shortage is huge, and we're constantly in neurology as a whole trying to battle that. But, it's hard because, as you mentioned, there are these large administrative burdens. But so you mentioned non-medical switching. What exactly is that?
Well, let's talk about that one, because I can promise you I have never had a patient come in and sit down in front of me and say, my insurance company non-medically switched me to something, right? That term, non-medical switching. Let's talk about that for a minute. So we've talked about generics, right? The medications that are biologically or bioactive. They're similar, very, very highly similar. You can trade them out. Mm-hmm. Non-medical switching, that has nothing to do with generics. Non-medical switching is when your health plan tries to force you to change to a totally different medication. So let's say that for my high blood pressure or for someone's high cholesterol, let's say the patient and the doctor decide this is the medicine we're going to use. Non-medical switching is done several different ways. One way the health plan does it is they just say, we don't cover that medicine. It's not on our formulary. Okay. Another way they do it is they'll say to the patient, yeah, you can have the medicine your doctor prescribed. Your copay at the pharmacy is going to be $75 a month for that medicine. However, if you switch to this medicine, not a generic, a different medication, your copay will only be $10 a month. Now, you can choose, patient, whatever you want, right? Okay, so who does that affect the most, right? The patient that's wealthy is going to take what they want to do what their doctor ordered, right?
Yeah.
The patient who is financially struggling, right? That difference, in fact, it only takes about $15 to have a patient call the office and see if the doctor will switch them. And so here's what happens to the doctor. I should disclose my father was a pharmacist, and I grew up working in drugstores, but here's what happens sometimes. So the patient goes to the drugstore and the pharmacist says, copay on this one, $75. And the patient, oh my goodness, $75. He said, yeah, if your doctor prescribed this one, the copay would only be $5. If you want to give your doctor a call,
yeah.
Patient calls the office.
That's
Who
right.
are they mad at? They're mad at their doctor now, right? The health plan has figured out a way to drive a wedge between the doctor and the patient. Somehow, Dr. Patton, you're supposed to know what the copay is for every drug for 12 different health plans that are active in your area, right? There's no way the doctor can know this. Right? And so they set up a dynamic where the patient calls up angry at you and your staff. I'm here at the pharmacy and they say I could get this other medicine, say it's just as good for only $5 a month. But the one you prescribed me is all this much. But they're not the same medicine. Right? And the doctor's, well, wait a minute. I chose this other one because of the other medical conditions you have and the other medications you're taking. This one goes better with those other medicines. That one does not go well with the medicines you're on. But the bad guys made the patient. And so therein is driving the wedge between the physician-patient relationship. And that is incredibly harmful to the patient. And it also adds to the burnout of physicians.
Yeah. And that's why I really wanted to have you on and talk about these things, because when I look at why I got into healthcare, it was to treat patients, and why I spent so many years in school and in training and CME credits and everything else to make sure that I know or try to do what's best for patients based on my knowledge. But it's tough when we're operating in this environment where you have all of these different things. And like you mentioned, we're busy seeing patients, so we don't have the time to really sit down with every insurance plan and figure out one medication versus the other. So, it's really important that the audience knows and understands to communicate with your doctors, communicate with your health plan, and make sure that that you're on the right treatment, and that we can get you what we feel is best for you.
I couldn't agree more.
So we still have a few minutes. I want to hear more about the Alliance for Patient Access and some of the work you're doing there.
Yeah. So the Alliance for Patient Access is a nonprofit founded in 2006, based in Washington, D.C., and it advocates for patient-centered care so that patients can have access to approved therapies. So the Alliance for Patient Access trains physicians in how to be better advocates for patients to get access to care. So we hold physician working groups and workshops on how to improve patient access to approved therapies, and how to push back on these utilization management techniques that insurance companies are throwing up as barriers to patients and to doctors. And so at the Alliance for Patient Access, what we hope to achieve, and what we have largely been achieving, is training physicians how to be better advocates and to make changes at the health plan level or at the level of Medicare or Medicaid. Let me give you an example. If I fight the battle and I do one of those appeals and another appeal and then an outside appeal, and my patient finally gets access to, say, this particular medicine for Parkinson's that I'm trying to prescribe, sometimes physicians believe that now the health plan, because we fought it out for Mr. Johnson, now the health plan will cover that medicine for all the other people in the health plan that have Parkinson's if they need it. Not true, right? They're just going to cover it for Mr. Johnson, and when the next patient needs it, they're going to deny it. Okay, so what at the Alliance for Patient Access, we want to train physicians to be better advocates and to work with health plans and others to change the policy so that all of the people in the health plan could have better access to care.
And that policy change is not just on the local level. I mean, it has to do with the state house, state capitals, and the federal capital as well. So I'm a big advocate for patients and for physicians, lobbying and really talking about these issues so that we can make these policy changes that are needed.
Agreed.
Well, David, Dr. Charles, thank you so much for joining today. I mean, we were able to just touch on a couple of issues. I hope we can have you back and cover a few more, but this has been really enlightening. And, I certainly have learned a lot more, and you've inspired me to be more of an advocate for my patients and to get involved with groups like the Alliance for Patient Access.
Well, thank you, Dr. Patton, for having me on. I wish you the best and the best to your guests.
Thank you so much, David. We'll see you next time. And thank you all for joining for this edition of Your Health, Your Wealth. Please subscribe and like, and if you took something away from this, please share with your network, with your community, with your family, and tune in for future episodes.